microphone. It was a good start, isn't it? Good morning, everybody. Lovely to see you all, and welcome to Bury St Edmunds for our January Public Integrated Care Board meeting. So, I'm going to kick off with a few comments and points, if I may. First of all, to note that we are live streaming, so everything that we do and say is open to the public this morning. And also to note that the agenda is busy, as you will realise, no doubt. Therefore, if we're going to get a break this morning, we have to be as fast as we reasonably can, and let's assume that the papers have been read when we're, apart from the presentations, of course, when we're dealing with each item. A few points, organisational board points. First of all, let's record a thanks to Steve Feast, who retired at the end of December from the board. So thank you to Steve for all the work he did for the ICB. And I don't see Nick Rayner here at the moment. Haven't had an apology from Nick, but I think this might be Nick's last meeting, if I'm not mistaken, before he retires. So thank you in advance to Nick for that. And also, I know there's traffic problems out there, so a number of people are stuck in traffic. But let's also record that this is Caroline Donovan's first public meeting in person from Caroline, from new CEO at NSFT. So welcome to Caroline. I have apologies from Pete Devlin, and I think Moira McGrath should be here to replace Pete from Essex County, but Moira not with us yet, perhaps also traffic problems. Apologies also from Jeff Dobson, Lisa Noves and Frida Batty, Nick Hume, but we have Shane. Thank you very much, Shane, for that. Andrew Reid, John Spence and Maddie Baker-Wood. So, any other apologies that I've missed there that we know of? No? Okay. One final organisational point. There's an item, as you will have seen in the pack, about the board self-assessment questionnaire. And obviously, you're all very well aware that we're a new board, we're a maturing board. Therefore, the self-assessment as we mature is going to be very important. We've got an item in the board pack on it, but could I remind everybody who hasn't yet filled in their self-assessment, please so to do, so that when we get to the March board, we can do a full report on including everybody's return. So let's then go on to questions from members of the public. We have actually received 4 questions. The first 3 are from Mr. Dooley, and I'm going to deal with them in this way. Mr. Dooley raised 3 questions. Firstly, on virtual ward costs, and particularly he referenced the article in the HSJ. Now, Vivian, when you present on the virtual wards, you're going to include a comment on costing, aren't you? And the fact, okay, and I'll leave that to you. But this is very much a work in progress. And so, as well as Mr. Dooley's other 2 questions, which were on the MAPS consultation and A&E excess deaths, we'll give a written answer to Mr. Dooley, including the updated virtual ward costing material after the meeting. And then we have another question from Josephine Murphy on dentistry access. Now, this actually is an update that Ed was going to give anyway in connection with the matters arising, items 23090. So I'm going to go to Ed to deal with both at once, and then we deal with both items in one go. Over to you, Ed.
Yeah, so on dentistry, Peter Whiteman will be bringing our dental reports to the March board, which sets out in significant amount of detail, all the actions that we are now taking or planning to take, and hopefully that will provide some assurance to the member of the public that we're taking it very seriously and have plans in place to improve.
Excellent, thank you very much. So then moving on to the next item, item 3, declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item other than those of which we are aware? No hands raised, none noted, thank you. Minutes of the last meeting, 28th of November 2023. There are 15 pages. Shall we see if we have any comments on block, please, initially for truth and accuracy? Any issues over truth and accuracy? No. Therefore, is the board content that we resolve to approve the draft minutes for 28th of November as presented as a true and accurate record? Agreed? Thank you very much. And Caroline, welcome. And I've just welcomed you to your first meeting. So welcome. Traffic is a problem for a number of people, apparently. Yeah. Okay. So minutes approved, which means we can then move on to matters arising. So we've dealt with 23090, the dentistry update. Thank you for doing that, Ed. I'm going to go to Richard, if I may, first for item 23119, the PDAF and Directorate Risk Registers, etc.
Thank you. So just to remind colleagues, this relates to the delegation of specialised commissioning to the ICB from the 1st of April 2024. And the PDAF is effectively the form, the methodology through which we've got to assure NHS England national team that we are ready and able to take that on. We have put it onto my own Directorate Risk Register. However, it's relatively low because we are moving full steam ahead with enablements to get that through to the board at its next meeting in March, Chair. And there will be a focus on it at the board development session in February. So we've got colleagues coming from my team and from NHS England to brief the board more fully on the implications of taking that on from 1st of April. Thank you.
Okay, so if everybody's content, we'll take that as a completed action. And then we have I'm going to go to Amanda for 2 items. One is 23142, the Bath Freedom Speak Up update. But Amanda, you've also got an additional matters arising that you'd like to raise. So over to you.
Thank you very much, Chair. So in terms of action 23142, this was relating to the freedom to speak up risk. Having reflected and taken into account the conversation at the last board, it does remain on our BAF, and I'll be obviously updating the board members when we come to that item shortly. And then in terms of the additional matters arising, which is not covered on the action log, board members will recall that there was a question raised at the November board from Frida Barty in terms of the board makeup from an EDI perspective, and it was acknowledged that we needed to take that action away. So from November board meeting, I have done some analysis. I've also benchmarked SNE with the other systems, and I will send an update the board members following today's meeting, Chair, which will have all of the details and hopefully confirmation of the question raised.
Lovely, thanks Amanda. And should we take that once you've circulated that update, we'll take that as completed, shall we? Yeah, okay. So those were the open items. Any questions or points on the open items? Then on the closed items, is everybody content that they are correctly closed, or are there any questions on any specific items? No, in which case we agree to accept and endorse the actions, etc. And then my general comment about the matters arising, is everybody content that the matters arising as presented correctly captured those matters arising which should have been captured, or are there any other items? So agreed, true and accurate record, etc. Thank you very much, everybody. In which case, item 6, Ed, I'm going to come to you for the general update, please.
Thanks, Chair. I've limited myself to 9 updates. I think there's I could have put a lot more in, but I didn't want to test your patience. The first update is to say that Ofsted and the CQC will publish their inspection report into SEND services in Suffolk today. It will outline significant concerns around SEND in Suffolk and with 2 priority actions around governance and timeliness of educational health and care plans. There will be an apology issued to families in Suffolk and a commitment to resolve the issues and to move them forward as quickly as possible. I'll be leaving this meeting early just to join a media briefing before midday. Suggest we bring the report to the next board, Chair, if that's okay with you once it's published. Secondly, a big thank you to all colleagues who managed the junior doctor strikes over the festive period. Whilst it was very challenging, exceptionally challenging time, particularly the length of the strike, the resilience of the system was good. And I think a comparison of our urgent care performance in December 2023 compared to 2022 has definitely improved on almost all metrics, albeit demand into the emergency departments has been down this year. One of the big improvements has been around ambulance performance, and my third update is to just recognise that the East of England Ambulance Service has recently come out of special measures, so congratulations to them on the work they're doing culturally and operationally, that is starting to pay dividends. Number 4 was just to recognise that the COVID-19 vaccination programme has nationally, I think, has formally concluded. It will now be mainstreamed through primary care and through other means. There's been 3.1 million jabs in SNE since 2020, so a hell of an achievement, and we're very grateful to all of the teams and the community and the voluntary sector partners who've been part of that effort. It's been an incredible programme of work, I'd suggest. The 5th update was pleasing as always to see you in the papers. So the groundbreaking at Newmarket Community Hospital, as we're starting to prepare to build the community diagnostic centre there. I think it's planned to be open in October 2024. We've seen the success and the difference it's made to the community in Clacton and the surrounds, and the more convenient access to diagnostics also will be benefited in the West Suffolk catchment too. So we're very excited about that development. The 6th one is to recognise the work we're now doing as an ICB in terms of engagement with schools. We've now held 2 STEAM events with council colleagues in Felixstowe and recently last week in Clacton. I was there at the event, as was Amanda, and we had over 200 Year 6 children, a number of children from Frobishers, which is a school in Jaywick. It was very deprived, particularly deprived part of the country. And it was a fantastic and inspirational event, showcasing all the different potential careers in health, or some of the different careers in health and care, as well as in Felixstowe Port and in construction. And it was really inspiring to see. So excellent, if I may say, kind of prevention work, supporting people and raising aspiration. Equally, the University of Essex have been inviting school children into the university to showcase some of the potential careers there, and also to give people an experience of the university campus that wouldn't necessarily have that opportunity. So some really good work I'd just like to commend. The 7th update was around building on the theme of prevention. We're now ranked 2nd in the country around reducing smoking in pregnancy. Made a huge step forward there, and also making big strides forward in terms of care processes in diabetes, and that was recognised by the Chief Medical Officer last week. So we're going to start to report more routinely the Joint Forward Plan metrics, which include a number of these areas, but it's really important, I think, as a board, we pay attention to those more preventative metrics and make sure we continue the progress. Final two things is that we've launched our staff consultation around the running cost reductions. We have made £6.2 million running cost reductions, but we've done it in a way that has mitigated so far the risk of any compulsory redundancies, and we hope to be one of the only ICBs in the country that does so. We have 14 post holders affected, which is obviously very stressful for them, and we're supporting them, but we have 61 vacancies within the ICB, so we're hoping to find solutions for everybody. And I think in part two, you'll have more of an update on that. And then finally, as I just referenced earlier, we'll be bringing our dental plan to the March board. At Prime Minister's questions last week, on the 24th of January, Rishi Sunak referenced the work we're doing at the University of Suffolk as something that is recognised nationally now, and people are very excited about. So it was lovely to have that recognition for all the team involved with that. So thank you.
Lovely. Thank you, Ed. Great update, very busy time, and thanks for the update, obviously, but thanks from the board members as a whole, I'm sure, to all those who have helped deliver the work behind Ed's update, which of course is significant across the system and from all players within the system, all stakeholders. So thank you to everybody. Any questions for Ed? Otherwise, if there are none, shall we say received and noted with due thanks, etc. All done? Thank you very much. In which case, let's move then on to the next item, which is the ICB annual report and accounts. And Howard, I'm going to come to you for this.
Thank you very much, Chair. So this is the first set of accounts for the Suffolk North East Essex Integrated Care Board, and they relate to the period July 2022 to March 2023. The board will recall that it gave delegated authority to the ICB Audit Committee in November to approve the accounts so as to ensure that we met an NHS dictated deadline of completion before Christmas. In the event, final sign-off of the accounts did not happen until the 19th of January, and we're still awaiting completion of the value for money report, although our auditors have said they have identified no significant weaknesses with that report at this stage. I would like it noted that the delay in sign-off was not the fault of our finance team. This is due to previously reported capacity issues with our external auditors, BDO. I can also report the following. The ICB has met its financial performance targets, including its duty to spend within its resources. There's nothing to disclose after the reporting period that would materially impact on the financial statements, and BDO have issued an unmodified opinion of both the financial statements and the regularity of expenditure. So a clean bill of health for the accounts, effectively. My thanks, as ever, go to the ICB finance team for their diligent and positive approach over what has been quite an extended period of time. And Chair, the board is asked to note the paper and the documents listed in the appendices.
Howard, thank you very, very much. And you're quite correct that we delegated to the Audit Committee at our November meeting. So we are simply receiving and noting here. Just before I go to board members for any questions that they may have, Howard, would you like to pass any comment on the work in train to prevent future delays so that we don't get a repeat performance, shall we say?
This is the last set of accounts that BDO will be doing for us. So our new external auditors, Ernst & Young, will be starting for this next financial year.
So let's note that, because we don't want a repeat performance. I know the board don't want to get into the detail here, but I know that no board member is pleased with that performance. Janet.
Thank you. Just to reiterate the thanks to the ICB finance team for taking the accounts over the line, and to give some assurance to the board that I will be working very closely with the new external auditors to make sure we don't have a repeat.
Yes, thank you very much, Janet. Thank you. So, with those comments and future actions noted, any questions for Howard or indeed Janet, of course? Otherwise, are we happy to receive a note? Agreed. Thank you very much. In which case, Howard, I'm going to stick with you and move us on to item 8, which is the finance report. So back to you.
Thank you, Chair. So I'll take the report as read and pick up on some of the key changes from our latest month 9 position. And then I'll give a short update on where we are with financial planning into 2024 and 25 and indeed future years. So first of all, a reminder that the system will spend about £2.2 billion on healthcare related activities during 2023-24. Another reminder that I'm using the word system to very specifically refer to our NHS partners with which our regulators monitor financial performance in aggregate. So those are the ICB, East Suffolk, North Essex Foundation Trust, the Ambulance Service and West Suffolk Foundation Trust. And our financial plan for this year is an aggregate break even. Within that, West Suffolk Foundation Trust have an approved deficit plan of 6.3 million, which is offset by surpluses in all our other system partners. This revised deficit at West Suffolk and balancing surpluses was approved at the board in November. At this point, I can report that all partners are on track to deliver their financial targets per that approval. I can also report that West Suffolk Trust continue to maintain their trajectory for delivering on their financial recovery, and that all agreed actions are either completed or in train as per the plan. The key risk to delivery is related to the ongoing industrial action for which no external funding has been provided for the actions that took place in December and January at present. But quite early on in January, the directors of finance in this system, including myself, agreed to maintain a balanced position, allowing for internal mitigations in the event that no future funding will be provided. We believe that we are possibly the only system in England to have been able to do this, and we have been assured by our regulators that any future industrial action funding would come down to systems on a fair shares basis and would not be related to financial positions. I thought I'd mention that as an indicator of our stability and also the maturity of the system, really.
Let's also note that commitment from above, Howard, shall we?
Thank you. One final point to note is the position related to capital, which is a little bit complicated, but essentially accounting rules under IFRS 16 state that operating leases must be recorded as capital. This is relatively new, and we recently received an 8.6 million adjustment to our system capital allocation, which we estimate to be about £29 million short. And that is short mainly because of the ambulance fleet renewal programme at E-East, which are all completed under lease arrangements, and that has not been recognised as part of this latest capital allocation. We're working very closely with our regional colleagues in NHS England to help facilitate a solution to this issue, and we'll continue to report that through Finance Committee. A quick word on 2024 25 financial planning. At this point, NHS England have released very limited information in relation to financial plans. We understand that this delay is in relation to ongoing discussions with Treasury in relation to key deliverables and in dealing with the financial pressures related to industrial action. So unfortunately, therefore, I'm unable to provide a specific update to the board on the respective financial positions for the next financial year. But I can say the following. First of all, we are in the process within the system of setting up some of our own key dates and processes and assumptions so that we can keep things moving through February in the hope that the guidance and final allocations will materialise soon. And that includes the assessment of pressures, gaps in services and assessments of programmes with non-recurrent funding. And we can also expect over the course of this forthcoming planning round a significant amount of scrutiny on hospital capacity and workforce, with an expectation that funding for the next financial year assumes the same capacity and workforce as was commissioned and provided in this financial year. But you won't be surprised to hear this, an expectation that more activity will be delivered. So therefore, a focus on productivity. And finally, the ongoing development of the longer-term financial strategy, in particular shifting investment towards prevention, will continue in earnest once we get through this immediate planning cycle. Again, Chair, the board is asked to note this report and update, and I'm happy to take any questions. Thank you.
Howard, thank you very much. And I think the board, you and the board particularly note Howard's comments around the continuing, should we say, adherence to new plan from West Suffolk. So thank you for that. And I'll perhaps ask you to say a few words in a minute, if I may. But can I go to Ed first? So over to you, Ed.
Yeah, I just commend Howard and colleagues for not revising our plan after the strikes. I think it would be tempting to do so, wouldn't it? But actually, I think the dividends of being honest pays off in the longer term. So I think that's the right approach. So thank you.
Mm-hmm. Yeah, thank you very much for that. Ewan, would you like to update us from West Suffolk's point of view?
Yes, thank you, Will. So there's been an enormous amount of work over the course of this year that has been across the entire organisation, some real strengthening of governance around the SIP programme, a focus on a reduction in high-cost staffing replaced by substantive staff, and because of the progress we've made, we're really now focusing our attention on 24-25.
Okay, thank you. So, colleagues, any questions or points to raise for Howard or indeed any board member? Otherwise, we're simply asked to note. Are we duly noting? With thanks to all those involved, and no doubt continued focus from the board, and a request for all teams to have continued focus, because in the end, again, as Howard emphasised, it's a system game, isn't it? So, all done? Lovely, thank you. In which case, let's then move on to item 9, the performance report. And Paul, I'm coming to you.
Yeah, thank you, Chair. As detailed in the documents, this report is for noting, but I'd like to say a few things, if that's okay, Chair. So you'll notice that within the report, there is an absence of quarterly performance reviews, which is a feature of this report. That is primarily because these have been rescheduled from April onwards, following the end-of-year review, and of course those will be reported in due course as we move forward through future board reports. You'll note the SOAC activity, which discusses the many challenges that have already been alluded to around industrial action, urgent care, etc., cancer performance, and that there is nothing that SOAC which to escalate to this board at this moment in time, despite the fact we have significant challenges in the system as we currently are. I think, though, at the last board, if you would remember, there was a conversation around publishing of essentially unvalidated data. And of course, we shouldn't and don't routinely publish that data for the simple reason that it changes once it's been validated, and actually should certainly not be in the public arena. So in order to try and address the question, you'll notice that within the first part of the report, there are a number of slides. I've simply picked some of the 4 key areas of challenging and performance. And you will notice that in terms of governance, it goes slightly deeper than what we normally talk about, which are simply the ICB committee. So sitting on each of the ICB committees, there are numbers of working groups that have a particular remit that fit into the ICB committees. You will note that they discuss and go through the various key performance indicators, and also provide their own report on an ongoing basis. What you'll also see through a set of slides is essentially the relationship between the reporting KPI at the board, the programs of work report that fits into performance as we move forward. What isn't represented in this set of slides is also the numerous number of meetings that take place at organizational level. So each organization, routinely review their elective activity, those feed into the various committees, etc. So that set of slides was really to try and draw together really the governance arrangement that we currently have in place to give ourselves assurances that we are reviewing, live activity, if not up-to-date activity and performance on an ongoing basis. So, Chair, I'll stop there. It was hopefully to try and help that conversation. Thank you.
Paul, thank you very much. And first question from Ed.
Yeah, so it's a question maybe Richard can field and maybe Caroline will have a view as well. So two things really. So out of area placements. So just to kind of highlight to the board where we are there. My understanding is that in Suffolk, we're making some good progress there. So, commend that. I think bigger challenges in Essex. So just be helpful to hear where we are and what we're doing. And then back to the send point I made earlier. I mean, the big concern for the board in terms of the NHS contribution to that, I think, is waiting times around NDD. I think going forward, Paul, I'd be really grateful if we could, because it's sometimes difficult to see the wood from the trees in this report, let alone in send, which is complicated. But for NDD is the heart of the issue for us that we need to resolve. So if we could have that as more of a headline metric, and Richard might say a little bit about what we're planning to do both in Suffolk and in Essex.
Thanks, Ed. So just in terms of mental health, inappropriate out of area, so just for the board's reference, that's effectively individuals that are placed out of county where actually there should be a place locally for them. So that hence why it's classed as inappropriate. Within Suffolk, within December, we had 4 individuals who were placed outside of Suffolk using 65 bed days. As of a couple of weeks ago, I think, Caroline, we were down to 1 person. So that's amazing. I'll be honest now, we should be obviously at 0. That's our absolute ambition. But when I look across at our neighbours, that's a much better picture than we see across the rest of the patch. Turning to Essex, I think it's fair to say, and Pete's obviously a partner over there, and Moira, Moira's gone. We've got a lot of work happening over in the Essex across the 3, and I'm coordinating across the 3 ICBs our recovery plans with ePut as our major provider. We are aspiring to get down to 0, obviously, as soon as possible. There is a significant business case that's being developed by the trust that they're working through at the moment. And we're also talking across the 3 ICBs about our current risk share arrangements in terms of how we manage out of areas. So I'll be able to update Ed, the executive, and then the board probably in a couple of months if we put a note either on the performance action, or I can bring something specific on that. Just turning briefly to neurodevelopmental. So that breaks down particularly into 2 areas, so ADHD and autism. Not uniquely, though the whole country is under incredible challenges in terms of the degree of demand rightly from parents, carers and their children and young people around appropriate support, including diagnosis where needed for those one or both of those conditions. We've got significant waiting lists in both the Essex part of our patch and also within Suffolk. We're working with our 3 providers, which is West Suffolk Foundation Trust, ESNEFT and NSFT, around recovery plans against those services. And indeed, we're bringing a business case to our executive on Monday, which looks at, just staring at Howard, some non-recurrent support to hopefully help towards reducing the autism wait list. And then we'll be developing a recurrent business case for later on in this financial year, which looks actually recurrently at what could we do differently also for ADHD, where it's a bigger challenge in terms of solving that. But I would say that this is arguably one of the biggest challenges we've now got in terms of our waiting lists. And obviously it's for some of the most vulnerable people that we serve. So more news on that in the coming weeks and months as we bring those cases through.
Absolutely, Richard, and I know the board's fully behind you in that focus on those who really need the services. Just before I come to Ed, you mentioned an update in a couple of months. Are you happy if we schedule that for the March board?
Yeah, that's fine. Yeah.
Okay, I'll come to Ed, and then perhaps Pete and Georgie, you may have some comments to make from your point of view, but yes, and Caroline as well. Thank you. Ed, you first.
So just the key thing I'm trying to understand is the Suffolk position is really improving. We're really proud of that.
For out of areas, yeah.
Out of areas. So what is it we're doing in Suffolk that is making a difference?
I don't think that's an easy answer, so I wouldn't want to flippantly try and make something up. I think partly it's the significant, amount of investment and change we put into place over the previous 3 to 4 years around developing the mental health collaborative and the joint working we've been doing across the county council, NSFT and ourselves. It is a more complex landscape in Essex, with 3 county councils up a tier and 3 ICBs. And we are looking at the demand profile to really understand why we're seeing more effectively more out of area placement. So at this stage, we've got to do more diagnostic work across the 3 ICBs with EPUT around that.
So more on that in March, Richard. If I just go to Paul first, Pete, and then Caroline. I'll just go to Paul. Is it on this subject?
Yeah, it is.
Yeah,
It
go
is.
on then,
It is.
go on then, Paul.
Part of the answer to the puzzle as well is we've also, as you remember, set up a system control centre, and we're actively working with the trust on a daily basis around patient flow. That will also contribute, I think, to some of the improvements we're seeing.
Okay, thank you for that, Paul. So, Pete, Caroline, Georgia, over to you to organise the order of play there. Go on, Pete.
So I think this is a concern for us as well. In EPUT, in North Essex in particular, actually, we're really struggling with, and we can see that in our delays in our inpatient services, so corresponding, obviously, with an increase in out area. And the concern extends, of course, to us in relation to ensuring that people who need a bed get a bed in a timely way that's local. So there's a kind of a clear investment across the system and integrated local care. I think I've been speaking to the Ops Director, Elizabeth Wells at EPUT, about us doing a further MAID event to try and understand whether there's sort of efficiency and processing issues. I think Paul alluded to that. What we've also done is we're now looking at the kind of characteristics of the individuals that are delayed in our inpatient services to make sure that to answer the question around sufficiency and range of community capacity. What we've also done this year through some use of the BCF funds is to increase our move-on facilitators so that we support the traction and flow right through our services. Some of you will be aware of this, but in North Essex we've recommissioned mental health supported housing jointly with the ICB and the local authority. We're comfortable that that's the right model. But we now need to make sure that we're sweating the asset of the model and that we're ensuring that people are moving through in a timely way through the services. So I think, Chair, just go back to the point, it's an issue and a concern for us. We need to get underneath the kind of multiplicity of the issues that are affecting it. And we need to answer the question about, do we have sufficient community capacity in Essex to support the pathway in and out, to prevent and support timely access in and out into community services.
So very much a work in progress. But
it is a work in progress, but it is an issue. It's an issue and a risk for us, and it's a concern, so we're looking into it.
Yeah. Georgia, do you want to add anything?
Very briefly, just to say, I think we have an opportunity with the SEND report being published today, and I imagine that over the next couple of weeks there's going to be quite a lot of work that we'll be doing as a system to look at any opportunities in terms of what we could do better. I mean, we know what the problems are. Some of them are national problems, some of them we can do something locally. But certainly my aspiration, as Richard has just described, particularly around autism and ADHD, it's just that whole customer pathway that Peter's just described, the prevention, if people are in crisis, any support, whether it's short-term or longer-term support that they require. So it's just a comment to say we will definitely be working together as a system, and I anticipate that the update at the next board, we will do that together, both across health and social care. Thank you.
Okay, thank you, Georgia. So then let me go to Caroline.
Thank you very much. So on the out-of-area placements, I think there has been some really good progress, which is great in that area, in Suffolk. And certainly, as of yesterday, there were only 9, and we had a fire recently, and we've got a closure of 8 beds. So as Richard said, it has got really down. And I think a lot of work we've done is around demand and capacity, safer, red to green. And I don't know what, because obviously I'm new, I don't know what collaborative we have with EPUT and whether we could be working more closely together across that, whether that's worth us having, and I'm sure there'll be lots of joint learning both ways, but I don't know if it's worth us just joining up around that and see if there's any learning to translate. In terms of the neurodevelopmental pathways, I mean, as Richard says, it's extremely challenging. Nationally, it's a really high priority for us, really pleased to see a collaborative approach across the providers, both NHS and voluntary sector, and really welcome the plan to move to recurring funding. I think that'll really, really help as well. Thank you.
Okay, lovely. And there's a lot of nods around the table, Caroline, to your joining up suggestion. Should we take that as an action for outside the meeting? Yeah, everybody happy? Yep, good. Any other questions or points are just on this? Is it on this specific item? Oh, go on then, Susanna. Yeah.
So just to the conversation that I'd already begun with Richard, but I think we should accelerate, is a piece of work through the ICP to engage people, families, communities, wider partners in the ICS, particularly the voluntary and community sector, in some kind of discussion about where we can share learning, where we can share experiences, and I think kind of more fully understand and enhance our understanding really of the issues at work here. So committed to doing that.
Okay, and should we say noted, agreed, indeed. So on this specific item, any further questions? Otherwise then on the paper in general, any points to raise or questions for Paul or indeed colleagues? Otherwise received and noted. Done? Lovely. Thank you very much, everybody. So let's move on to item 10, the board assurance framework. Amanda?
Thank you very much, Chair. So the board assurance framework, as we know, is a key document that I present at every board meeting that maps out the sources of assurance for our strategic risks. As an assurance map, the board assurance framework should help answer the question, do we really know what we think we know? Or in other words, how confident are we that the controls that we have in place as intended, and more importantly, do we have the right assurances in place to identify if they aren't? So from the last board presentation in November and moving to January, we have no new risks added, and indeed no new risks have been removed. But I would like to draw the board's attention to five risks that have been updated, and after I've gone through those five, Director colleagues may wish to add to what I have presented. So if we look at risk 3 first of all, and this is regarding our waiting list and not meeting the constitutional target of 18 weeks, an additional gap has been identified that ring fences bed capacity for some specialties. And then moving to risk 11, cybersecurity, an additional assurance has been identified since the ICB undertook a self-assessment using the NHS Data Security Protection Toolkit, which showed that we were performing well against the National Data Guardian's 10 data security standards. Moving to risk 16 pertaining to E-East performance and quality, we've actually closed the gap since last meeting with regards to the improvement plan, which is now being regularly updated and reporting to us. Moving to risk 25, this is regarding our failure to meet statutory ICB financial targets. 3 new controls have been listed, including a diagnostic review, which has been commissioned, the production of the West Suffolk FT financial recovery plan, and detailed review of the escalation and de-escalation process. And then moving finally to risk 30, as I mentioned in the action log earlier on, the freedom to speak up arrangements will continue to be on our BAF. Further work will be taking place through the Quality and the People Committee, but we do need to ensure that we do have the regular and important levels of assurance to ensure that we have fit and proper arrangements in place. A further piece of work that we are doing is to ensure that freedom to speak up is extended to primary care, and that's something that we're working through with the Guardian Service over the next 18 months. So in terms of those 5 risks, I thought it would be worth noting that we have seen some additional improvements since the last meeting. And then if we look to how BAF is linked to our system assurance framework, we will see that we are now working through closer alignment. And an example is risk 29, consequences of climate change, which aligns to our ICS's aims for environment and the estates. The SAF, as we know, is evolving, and the ICP for the first time saw the entirety at its meeting in December. And moving forward, we will ensure that our BAF and SAF are more closely aligned as we move forward. And then if we look to linking our BAF to further ICB strategies, that is something that we are committed to, and I would just draw attention to the joint forward plan where we need to ensure the two are more aligned going forward. And then in conclusion, Chair, I just wanted to make the board aware that we continue on our risk management journey, if you like, and we are undertaking a root and branch review to inform our BAF moving forward. We're working to make sure risk management is a core part of how we work and how actually it helps us as a board manage our agenda and indeed that of our committees. So I'll pause there, Chair, but I'm happy to take any questions or indeed fellow director colleagues may wish to add anything regarding their risks.
Amanda, thank you very much. Let me start with Ed. Over to you, Ed.
I think someone's put something in my coffee this morning. Lots of questions. Can we just triangulate the last conversation we had around NUD and out of area placements with the BAF? Because I don't think, unless I'm missing, I can't see it on there. And I think if we're saying this is a big priority for the board, a big risk, it should be. So maybe we could just do that work in between now and the next board.
So update at the next board.
Yeah.
Richard, is it on this subject?
So yes, it is. So out of areas, we'll include more specifically on, we've already got the mental health risk on the BAF, so we can bring that out a little bit more. I would suggest possibly, Lisa's obviously not with us, but if Lisa and I have a conversation about SEND more broadly rather than NDD specifically, I would have thought it would probably be more appropriate to have something on SEND, which then could break down into some of the areas, because although NDD is a significant challenge, we've also got challenges in other areas like our educational health and care plans and our CAMS waiting lists as well, which will link into SEND.
Number of nods around the table as you were both speaking there. So subject to what Andrew is about to say, are we happy if we send this to the exec team for focus and to bring back to the board? Yeah, Andrew?
Thank you very much. Amanda, really welcome the staff and freedom to speak up, particularly with regards to EDI. It's a massive step along that improvement journey that we started over a year ago. So great to see that from an EDI perspective. With regards to cybersecurity, we have very much in the past focused on our internal cybersecurity, looking at our own organisation's arrangements, but we are really becoming increasingly aware of the risk that cybersecurity places to the overall system and are planning to review the risk along with colleagues in the digital team to make sure the risk encompasses that in future. So there may be a change in future boards, but I'll include that.
Yeah, noted. Okay, thank you, Paul.
Yeah, thanks. It's interesting, isn't it? One, I think the first one, Amanda, you raised was the risk around RTT, and it's an interesting one because, of course, patient have got the statutory right to be treated within 18 weeks. But again, that makes the point that when you look at the integrated performance report, it talks to the RTT, and we are very much into recovery mode. Essentially, we are dealing with long wait patients at the moment and getting down to 65 weeks at the end of March, with a view, I suspect, when planning guidance come out, that there will be a diktat we should get down to the 52 weeks, essentially. So whilst I think it is absolutely correct to recognise the failure to meeting RTT, we have to recognise that we are in recovery, and actually you need to read both of those reports together to give you the assurance that you actually need, to understand the journey that we're on in terms of that particular recovery. And I think it's also fair to say that we tend to look at these things at a very high level. And I know that organisation, and I've shown, for example, Shane, sorry, there are clearly, where possible, specialities that are trying to get into it much more quickly than other specialities. Like orthopedics will take some time, but other specialities won't. So the conversation. So again, it's quite nuanced in terms of its approach. So we need to recognise the detail that sits behind all those things. So just a general comment that it's not just a straightforward RTT conversation. Thank you.
Do you want to comment on that, Amanda? Agreed? Noted? Good. Thank you. Thank you, colleagues. Any other questions? Otherwise, with those, let me call it those pieces of future work and referring back to the board with work in progress from the exec team, as discussed, are we happy to approve the BAF as presented today in the paper? Approved? Good. Thank you very much. And item 11, update on the NSFT mortality review. Andrew.
Thank you. As usual, I'll take the paper as read, but just want to draw a few matters out for focus, and then I'm happy to take questions if necessary. The report's been prepared collaboratively with Norfolk and Waveney ICB and also with Norfolk and Suffolk Foundation Trust, primarily to service the questions that were presented to us by the Norfolk and Suffolk Health Overview and Scrutiny Committees, but also to provide an update for this board, the Norfolk and Waveney board, and also the NSFT board. So a similar, if not identical, paper has gone to all those 5 places. I think it's also worth saying that the work you will see in this for NSFT has been achieved, and I'm going to say it's quite considerable work, has been achieved in the context of enormous organisational improvement. So this is not the only thing NSFT have been doing, and it really strikes me when I look at the breadth of improvement that NSFT are undertaking at the moment, that they've achieved as much with this mortality data improvement as they have. So the paper describes the arrangements for governance, for improvement in mortality data reporting, but also in learning from deaths. It provides a fairly explicit update on progress towards actions and indeed completion of the majority of actions that were identified as a result of the Grant Thornton review that we saw last year. And it also responds to several questions that came from both the Norfolk and the Suffolk HOSCs in a bit more detail. Caroline Donovan, who's with us today, has really given this, as the incoming Chief Exec for the Trust, some considerable personal attention. I'm very aware of her touch on this and the difference that's made to the improvements for NSFT. And she might want to say a few words just to draw out any matters in the course of questions.
Thanks, Andrew. Caroline, you're welcome, and we're loving. We're waiting with bated breath.
Thank you very much. Thank you for kind words, Andrew. A lot to live up to. Yeah, this is a really high priority for us, as you can well imagine, and really, really welcome the approach that we've taken and the support with partners. So it's really great to see the two ICBs working so constructively with the Trust. I guess the report is, and the update to the HOSCs was particularly around the data issues that came to light last summer. For me, there's three real priorities for us around this work stream. Excuse me, I've got a cough developing. Firstly is clearly that we can articulate the data properly. And we're really focusing obviously on the Grant Thornton report, and you can see that we have made good progress, and we've implemented a new system. Really important going forward is that we can articulate where people have died from mental health related deaths separately. Second priority is making sure we really do learn from both deaths and incidents, serious incidents. And the third priority is to do everything we can to work in a co-produced way with our communities, bereaved relatives, service users and carers. So yeah, really welcome the work. It's certainly work in progress and a lot more to do, but we'll be reporting on it to our public board every meeting as well. Thank you.
Okay. Thank you. Do you want me to come back to you, Andrew? Quick question from me, if I may. You know, in the appendix, there's a red right at the end on, it's part 2 of item 16 around the external verification of the data, and we're waiting the data pathway and so on. Do you just want to explain why that's red, given its waiting?
I can't see that bit in the paper, but I know what the issue is in terms of external verification. The data went live on the 5th of November. The new system went live on the 5th of November, recording data from the 1st of November. We need to have a run of the data at least for a quarter, if not 2 quarters, before we can have it externally verified. As you can imagine, we need to make sure it's up and running and all the glitches are worked through. Okay, so I think probably the ambition for that originally was too high in terms of the timescale.
It does say above, you know, waiting for developed and implement every 6 months audit process and so on.
Yeah.
So it's not red because nothing is happening. It's red because
it's because it wouldn't be appropriate yet. Yeah, and we will be taking that through both internal audit, which will be external company, but also an external audit probably as well.
Might be worth considering whether that should be red, given that it's if you know, but. Leave that to you guys. Did you want to come in, Andrew?
Well, just to see for what it's worth, that we've discussed that several times. We completely support that position as well, that now is not the time to do external audits, and we need to be absolutely sure that this is working as intended.
And was indeed discussed in depth at the Health Overview and Scrutiny Committee, wasn't it, as well?
Okay, good. So it's on your agenda. Excellent. Any other questions or points from colleagues? Ed?
I guess it's just a reflection, really. I mean, fantastic to see the progress being made and the ownership, particularly from NSFT under Caroline's leadership. But we made a public commitment around co-production when we received the report originally, and it's just I think it'd be good just to reflect on where we are with that kind of journey around co-production, whether we we've now moved away from it because we need to kind of get more of a grip in-house, or whether we're still absolutely committed to the co-production with bereaved relatives. I know this is a very difficult area, but we did make public commitments around co-production.
Yeah, I'm very, very happy to pick up, and I'm sure you will be as well. Absolutely not. We're not moving away from it in any way, shape or form, Ed. Obviously, there's clear complexity to the way that we're working, and it's really important that we work as sensitively as possible. We have established, because we need to focus on making sure we're learning everything we can. At the moment, we're going through the last 10 years of prevention of future death notices, making sure that we have embedded learning whilst we've responded to all the coronial action plans. The most important aspect is making sure that those improvements are embedded. Through the process that's been set up internally, and the first meeting has already happened, we've had a variety of people, service users, carers, and invites for bereaved relatives. We recognise that it's a high priority. We haven't got it right, and there's certainly more to do. But Gary O'Hare, who's leading this whole work stream, is working really closely with obviously internal PPL, community groups, and our ICB partners around that. Thank you.
Okay, Andrew.
And just to add to that, so I attended the first meeting of the, I don't know what the group's called, I can't remember, Carol, I'm sorry, it's a long name with lots of mortality words in it. The first meeting of the co-production, the collaborative group that NSFT are running. There was a bereaved relative in attendance there and clear plans to include more bereaved relatives, patients and carers as part of the work. There's also a commitment to support any bereaved relatives, carers or patients who worked with the group, with again an explicit recognition that bereaved relatives may have complex grief and may have very specific support needs, and that might need to be bespoke if necessary.
Okay, thank you. And Caroline, would it be fair for the board to also note that you're planning to come to a board workshop in February to present on the strategy and future timelines, and then the current plan will be to public board in March?
Yeah, subject to the diary commitments. We'd really welcome that. And that's a more strategic update around the overall improvement programme, of course, of which learning and deaths is one of the strands. That would be really helpful. Thank you, Chair.
Excellent, thank you. Any other questions or points otherwise received and noted? Everybody content? Lovely. In which case, then West Suffolk Alliance. Now, Peter, I'm going to start with you, and I know you're going to introduce colleagues.
Absolutely, thank you. And thanks for the opportunity to present this item. You've got in the papers we have a regular update that we do just on what we're up to in the Alliance Committee, so that's in the papers. But our main item really was to invite Vivian and Caroline along to describe the really impressive work that's been going on with the virtual ward in West Suffolk as part of a West Suffolk approach, but also linked very closely to the ICS approaches with ESNEF colleagues. Thank you.
Good morning and thank you very much. My name is Caroline Millard and I'm the operational lead for the virtual ward. I'm here with my colleague Dr. Vivian Yu, and we're here to update you on the work we've been doing to establish the virtual ward in West Suffolk. So we launched the virtual ward in West Suffolk at the end of November 2022 to care for patients at home. The patients we care for are patients who would otherwise be in hospital, and they're receiving hospital-level care at home. They're remotely monitored, wearing wearable devices which transmit their vital signs back to our hub, and we provide them with kit which enables video calls for daily ward rounds and messaging and telephone calls, and they receive home visits from our nursing team. As I say, we went live at the end of November with a number of patient cohorts and pathways, including heart failure, respiratory, frailty, acute kidney injury, and intravenous antibiotics. Since that time, we've added a general medical pathway. So we're looking after a broad range of adult medical patients at the moment, although this month we started to accept and onboard our first trauma and orthopaedics patients as well, so moving into surgical care. From launch at the end of November to the New Year's Eve, which has just gone, the end of December 2023, we cared for 674 patients, and they were with us for a total of just over 6,600 bed nights. Thank you. We are passionate about working with our patients to develop our service, and aside from clinical contact, members of our team speak to patients on a weekly basis to gather qualitative feedback. We also have some quantitative data, which I'll share with you on the next slide. From the 674 patients cared for to the end of December last year, 208 of them responded to our discharge survey. We asked them to complete a survey on the remote monitoring platform prior to being discharged from our service. We asked them 7 questions. I've put the answers to 4 of them here. And I think you can see that patients largely love the virtual ward. I think that comes over loud and clear. Patients enjoy the care that they receive and they enjoy being looked after at home. So the feedback around daily reviews and care, investigations and treatment, and the helpfulness of our virtual ward staff is really high. We're pleased with the 84% satisfaction rate, which has been fed back to us in terms of ease of use of our digital platform, but it's a real area of focus for us at the moment. So how can we make it easier for patients to understand how to use the technology? This doesn't read terribly well, I don't think, as it's projected. We've got absolutely hundreds of these plaudits and stories from patients about how they've enjoyed being on the virtual ward. And just a few words really about the key benefits of virtual ward. So reduced length of stay in hospital, avoiding potential complications. Although patients aren't physically on a ward, they are still able to benefit from daily video calls and contacts with our nursing team and our medical team, which is led by Dr. Yu. We have a pharmacy team and a dedicated pharmacist who reviews medications and provides guidance to our patients. And we provide a lot of education by our specialist team to our patients, and links into our emergency department, our SDEC and our clinics for admission avoidance and specialty follow-up on an urgent basis. I'll hand over to Dr. Yu now to tell us a bit more about how virtual ward works.
So I just wanted to describe what our current position is and what a day on a virtual ward might look like. So we operate 8 a.m. to 8 p.m. every day, and we have a dedicated out-of-hours team as well. So patients are looked after 24 hours a day, as they would do if they're in hospital. So as Caroline mentioned, there are daily ward rounds, usually led by myself, as well as a team of medical and advanced clinical practitioner staff. And we have a daily board round at 12 o'clock every day, which is supported by all of our specialty teams, so that patients get input from all of the specialists, and also we can have cross-cover from different specialties if required. And that's quite a unique feature of our virtual ward, and it was highly commended when the GERFT team came to visit us yesterday. We're also supported, of course, by our wonderful nursing team, who our patients love so very much, and also support workers. We have dedicated therapy support, including physiotherapy and occupational therapy, and of course our lead pharmacist as well. So we talked about our current position of having 40 beds, a capacity for 40, and also plans to expand that capacity in the near future. So Caroline has already mentioned that we're working with our colleagues in trauma and orthopaedics to trial a pilot, which has already commenced, to look and see whether we can build a trauma and orthopaedic surgical pathway for those patients. We hope that this will link in with some of our existing work in the frailty and acute kidney injury pathways as well. What's really very exciting is that we're hoping to trial a single point of access referral line for community admissions in order to help increase the number of step-up admission avoidance referrals due to start in February 24. We're also working with colleagues in other departments such as general surgery, palliative care, children and young people's wards, and also diabetes, so that we can extend this virtual ward model of care to any patient which would benefit across the hospital. So we see the virtual ward as being central to many of the other flows through the hospital. So not only from the front door village, so taking referrals daily and regularly now from our emergency department, the same day emergency care, and of course our acute admissions unit, but also linking in with our relatively new but well-functioning frailty hub, where a lot of our frail elderly who would benefit from being at home, avoiding delirium and falls, come straight through into our virtual ward. And through the Frailty Hub, we're now also onboarding patients directly in care homes. So we're extending the virtual ward to those really who would benefit the most. We've always had great referrals from our inpatient wards and clinics, but we also hope to link in with system initiatives such as the Unscheduled Care Coordination Hub. Also, as we transition into the community division in February, we hope to increase referrals directly from primary care and also from our integrated neighbourhood teams and community matrons. So as with any brand new service, there are always going to be opportunities for improvement. As we again transition through into the community division, there will be a look at whether we can have a better way of integrating our nursing teams with the locality teams. We're adopting a flexible approach to recruitment, and we also hope to extend some pilot work which we have done with voluntary networks to see if they can provide increased support for us. Nationally, there's always been some difficulty with clinician confidence, as with any new model. So we're going to work closely with primary care colleagues and community colleagues to increase step-up referrals. And we're also working with certain care home providers to step up directly from the care homes without involving the front door, hopefully. We have an ongoing communication strategy within the Trust, including regular staff briefings, and also communications with the ward teams, and we maintain a visible presence on the main inpatient wards every day. And in answer to the initial question about the costs, we're undertaking a comprehensive service evaluation with colleagues at the West Suffolk, which will look at costs and finances and also benefits realisation from the virtual ward as part of that. Of course, the West Suffolk has slight infrastructure difficulties, and we're looking to see how we can embed our newer, bigger team within that infrastructure, but also looking at how we can refine and improve our operational and clinical pathways as well. So as the system lead for the virtual ward, we work very closely with colleagues at ESNEFT. And when the GERF team came to see both of our virtual wards this month, one of the things they commented on most was how well we work together as SNE, as a system. And I think this made us quite unique, actually, in many of the virtual wards they visited. We have a joint approach to the provision of out-of-hours care. And hopefully, we're going to be working with another system partner, eEast, who will then provide a full 24-hour support for us from March 24. We're also looking to have a co-production approach towards the long-term digital monitoring platform. From April, we're going to have one digital monitoring platform for the whole ICS, which is great. But also, we're looking to make sure that it is digitally inclusive for all of our patients, especially perhaps some of those frailer older patients who may be a little adverse to technology. We also have a shared approach to developing new pathways, including that for palliative care and the children and young peoples. And of course, we had a joint approach to our GERF review, the reports of which are awaited. So just to look at the new planned priorities for the beginning of 2024. As well as the ones we've already talked about, we obviously want to embed and consolidate the work we've done on the pathways and expand new ones. The new central access referral line and ability to onboard at home, I think, will really increase the number of referrals we get. And of course, the pilots with the care homes and also hopefully with volunteers will provide, again, exciting opportunities to expand the virtual ward approach. So that's all we have to say, and I'm happy to take any questions.
Vivian, Caroline, thank you very much. So a number of questions. The hands are coming up. Let me go around. There's so many hands. I'm going to go around the table. I thought, Shane and you may well want to comment as well. So let me just go around the table. Paul, I think, did you have your hand up?
Yeah, just a few things, if I may, Chair. First of all, thank you for your leadership in this. I think it is a definite shift in culture now we approach patient care, and I think that's a really important point to make. And I think the point around, clinical, sort of understanding and trusting the system that patient can be well looked after is a cultural of something very difficult to achieve, which is why maybe we got off to a bit of a slow start, but actually we are gathering pace at the moment. I guess my question is, we often talk about virtual wards as a separate issue to bed occupancy. And I'm really quite interesting to understand how we marry that two conversations together. So today I could look at one of our hospital sites and say we're 95-96% bed occupied, but we have 20 virtual beds empty at the moment. And actually, if it is truly working, then I think we should be analysing the impact on inpatient beds and what capacity it frees up. And I just wondered whether you have a view on that. Thank you.
Yeah, absolutely. And I think that we work very closely with our patient flow team. We have multiple times a day conversations with tactical, for example, and we maintain a presence at the hospital bed meetings. I think what is true is that our patients are generally sicker when they come into hospital, and not all of those very sick patients are suitable for the virtual ward by dint of, for example, if they require inpatient operative care or an intensive care unit, or indeed they are very, very confused because they have delirium and therefore are not safe to be supported. I think one of the key areas that we will be looking at together with colleagues from ESNEFT is actually, can we refine our pathways? Can we look at those pathways to make them more inclusive? Do we have now the clinical confidence to expand the virtual ward offering to a wider group of patients? And that's why we are undertaking work to look at new pathways, for example, in areas where the virtual ward has not gone before.
Gone for.
I can just quickly come. No, absolutely. I absolutely understand that. I guess the point that I'm trying to make, which is an obvious point really, is if we look at the total number of virtual ward that we have, which I think roughly about 70 in Sydney and about 40, going up to 50 in West Suffolk, we've essentially created an actual 3 to 4 wards. And actually, it's how we use those wards, and actually we measure the impact of those wards on our overall performance and our front door activity and all of those things. It's quite key to understand it in a joined up way. That was just the point I was trying to make. Thank you.
I think all board members are with you with that question. It's not to doubt the issue, but to the evidential proof of value for money and performance, of course. Richard.
Firstly, thank you. Really helpful to hear the update. I think this has got so much potential. If it's not too much trouble, I'd love to come and either visit ESNEFT or West Suffolk just to see it in action about how it works. That'd be really helpful. 2 points, and it might be Caroline will make a similar one. I think this has got applicability into mental health. And at the moment, it's brilliant that it's PAN's system, but I think it might be helpful if we have a conversation offline around is there applicability, which I think there is, into the sphere of mental health, particularly in the context of the earlier conversation we had around capacity, but also we've got a big piece of work to do by June, which is around a 3-year delivery plan for improving mental health in patients. So this could be a real feature.
Let's take that as an offline
Could you
action.
just comment briefly, though, on the children's work, just very quickly, because you talked about that also being an area. I just wondered how plans are developing on that. Thank you.
Firstly, we'd be really happy to have a conversation about what we've learned in terms of virtual ward and how that could be expanded for mental health patients. I think Viv will want to say a few words, and perhaps better if I don't comment on the specific clinical presentations for children and young people. But there are 3 or 4 cohorts of children and young people who we've identified for a pilot. I think that we'll probably pilot towards the summer. I guess it is quite a new area for us, and what we've done when we've expanded our adult pathways is, so we have an infrastructure in our virtual wards. So we have a core team of staff, we've got the remote monitoring equipment, we've got the specialist pathway teams wrapped around us to support us. With paediatrics it's a little different because we don't currently have paediatric nurses, so they need to be recruited. So there's more of a lead time around children and young people, but we've got a really effective project group up and running, as I say, hoping to pilot towards the summer.
Thank you.
Okay, thank you. And just moving down the table, Caroline, you're next.
Yeah, just really impressive, really well done. I think it sounds fantastic and really innovative, and agree with the potential for it and the impact on vet days. That's really great. And just to Richard's point, well, I guess to your point, I think particularly around the older adult pathway for mental health, I wonder if we could connect our older adult teams in. I think that might be really helpful. We've got quite a lot of experience about integration of older adult physical and mental health, particularly people with dementia, but also functional mental health. I'm very happy to have that conversation. I think most broadly on mental health, crisis teams should be doing something very, very similar. Crisis mental health team model. I guess what I was particularly interested about is one of your challenges, which all of our challenges are around staffing. And you said that one of the solutions to that was a flexible approach to recruitment. And I wonder if was there any learning to translate what that means?
Good question. Yeah.
I mean, I guess off the top of my head, I have a couple of comments. So I think we've done a couple of things. So an example is we really struggled with therapists. So we had in mind we want this therapy package at this level, and we're just unable to recruit for a year. And so we had to think a little bit differently, and actually an OT came to us and said, I'm interested in this, could it look like this? And we negotiated. So we were really agile about what we were looking for and able to adapt that. We've really taken a test and learn approach. There's no, obviously, there's no recipe book for virtual ward because it's really new. I think we have ACPs. So as well as Dr. Yu and a trust grade doctor, we have support from our pathway consultants, but we have a team of dedicated ACPs as well. But that wasn't, we have that now, but we didn't have that when we went live. We were actually rotating from AAU and ESTEC. So I think we've had to try a range of things around recruitment, and some things have flown and been brilliant. Other things we've had to really adjust and try something different until we found the thing that works. May I come back to mental health just to say my background is ops in CAMS actually, and I do often think of the potential opportunities for mental health patients, so would love to have that conversation. Yeah, lovely. Thank you. Thank you very much.
Great stuff, and we'll take that as another out of offline action. Thank you. And sorry, I know I said I'd go round the table, but Amanda, I know you raised your hand. Was it on the workforce issue? Do you want to come in?
Thank you, Chair. And it follows really Caroline's question around the flex approach to recruitment. And my question was around the opportunities the virtual ward presents in terms of maybe looking at your skill mix differently to how we've done it previously. Do you have a comment on that at all?
I think certainly Caroline's described some ways of the flexible approach, and also it's not staffed as you might see as a traditional medical ward. We've had to look at it quite differently. It certainly has a different staffing structure from that. And so, you know, we would normally have significantly larger numbers, for example, of doctors on a ward. We've had discussions with HEE about having trainees coming into the virtual ward as a way of the future. And we certainly had agreement from the foundation program director to have foundation trainees. But we all know that trainee doctors don't come immediately because of the training program. So we've had to adopt a different way of doing things, including with our ACPs, and we're supporting them through their professional development and training as they go through their masters. So that's been one thing that we've done differently from a traditional approach. And also the NDT, where all of our specialists come in to provide that input at midday, meaning that we don't necessarily need to have specialists all day in the virtual ward, means we can make the most of that specialist input for a short period of time, but our patients still get that level of input, and sometimes cross-specialty input has been another way of doing things. So we have a team of generalists, but with a specialist, if you like, coming in and parachuting in to help us out at certain times, means that we can then run a sort of a larger capacity for a similar number of staff.
Thank you. Could I just have one other quick question, please, Chair?
Of course, Amanda.
It was around retention. Is it too early to say whether your retention has improved, or is that part of the journey still?
I think that's definitely part of our virtual ward journey. I think certainly because it's a very new model of care, it's very exciting, and some people who have come have chosen to stay, and some people have obviously come and discovered that maybe this way of working isn't quite for them. So I think that's probably something we will continue to review on a longer term basis, given that we've been running for just over a year. I think it's a little difficult to comment at this stage.
So work in progress, but learning all the time. Thank you. Kirsten.
Thank you. Thank you for the presentation. Lots of really useful information in it, and particularly pleasing to see that patients are very positive about the system. But the question I had was more about families. I wondered if you'd spoken with families, and particularly family members who are caring. This will have an impact on them, and you know, we must remember that at the moment pressure on family carers is pretty high, so unintended consequences might be, you know, more of a negative impact on family carers. Have you any information on that?
I think we both may like to comment on that. We've started conversations with Suffolk family carers. It's at a really early stage, but they're obviously making us think about the impact on carers. I know Viv will want to comment from a clinical point of view. So I will just say that we've started that conversation, and we do provide as standard the Suffolk family carers some background information and contact details.
I think from a clinical perspective, it was something that we talked about with system colleagues actually from the very beginning about how we could minimise or lessen that impact. I think one thing we have found is that sometimes families do pitch in, but actually they actively want to. Many families come to us and say, we don't want mum, dad, aunt, uncle to be in the hospital. We would much rather have them at home. They feel safer at home. They are better at home. So actually that's the most common comment that we get is how can we get mum or dad out of hospital and back in where they do belong. We do have nurses who provide welfare visits, so they get a welcome home from hospital call straight away, and also the nurses will go in and check in on that patient the next morning after they've been admitted to make sure that everything is working as they should. So there's no additional obligation placed on carers, for example, or their families to help, although many do choose to and would like to do so. And we also have excellent support from our medically optimised team, for example, from our UCRS, so our early intervention team, also from our Pathway 1 colleagues for reablement, and also our therapists now also go in to do home assessments. So actually the patients are able to have all of that support if required at home. But we do find that patients and their families really like being on the video calls together. So the communication often is improved because they're not ringing around wards trying to get hold of a doctor, but actually they're speaking to the consultant every day on the video calls, which they really like. And actually one of the qualitative feedbacks we get is that they feel that communication is improved and that they feel more empowered to ask clinicians about their care because they're sitting at home with someone next to them.
Go on, follow up, Kirsten, yeah.
Thank you. That sounds really positive, and reassuring that that's happening. In the instance where a family carer really needs a break and they're hoping someone will go into hospital because it is going to give them an opportunity to, sort of recuperate themselves, is that a negotiation that can happen, and is that possible?
Yeah, absolutely. And I think normally we obviously ask the patient for their consent to come to the virtual ward. And as part of that onboarding process, we do ask, would you need any additional support? Can we speak to family who may be supporting you or looking after you to make sure that everyone is on board before you come? And that's usually a very normal part of our onboarding call. So obviously, if there are key objections raised or it's not deemed to be possible, then we then discuss with the ward teams how the patient is best placed. We wouldn't, of course, force someone to go home with the virtual ward if they or their family didn't feel comfortable to do that.
Okay, so just before I come to Ewan, we went into this item 10 minutes ahead and we're now a couple of minutes behind. Now that is not a criticism at all, it just shows the level of importance and interest in this subject. But if we're going to get a cup of coffee at 11 o'clock, we need to accelerate. So, Ewan.
I shall be brief. So firstly, thanks to the team for all the hard work. Just perhaps two things that I would say. The conversation earlier about impact, I think that the team have taken a very purist approach. Some other virtual wards around the country have admitted lots of patients. You can't be 100% certain they would have been inpatients or not, but the team has taken what I think is the right approach to make sure it does decompress the hospital. And secondly, just a signal, we'll talk about the new hospital programme later. This programme is quite a big part of our plan.
Excellent. That's good. I think we'll take that as noted. Go on, Paul, if it's quick.
Just one quickly. So the UN sort of has gone where I was going to go, which said we took a very purist approach to this. We could easily have counted patients that we imagine already differently with the system. And a general point I want to make is there is some synergy between other processes and systems that we got for patients as well as virtual. And at some point, we ought to try to bring them together in terms of principles of care, in terms of virtual technology and all the things together at some point in time. But absolutely support Ewan's point. Thank you.
I'm going to take that as noted and agreed. Yeah, Andrew?
So I'll be quick, I'll speak quickly. Virtual wards is a great example of risk spreading, isn't it? It's taking risk out of hospitals and putting it somewhere more appropriate and allowing hospitals to really deal with high-risk patients where required. So it's exactly what we need at the moment. The patient feedback is phenomenal. I mean, I think we need to underscore that. It's such good patient feedback within a year is really great. I think I really want to call out your leadership in this, Vivian. I mean, the whole team is massively important, but I personally became aware of you when you stepped into a system-wide role, and the difference you made to the ICS virtual ward programme when you did that was absolutely tangible. So you should be highly congratulated for what you've done here. You're a very collaborative leader and you work well across different sectors, so I'm delighted to be able to work with you. And I think the work that your whole team has done should be remembered as a core reason that we've been able to keep emergency departments running this year. Our urgent care pathways only work because you've had 600 odd patients in virtual wards So again, you should be incredibly proud of that. The challenge I've got for you, and it's one maybe to take offline, is how do we make sure virtual wards at best improves health inequalities and at worst doesn't exacerbate them? But that's probably a more difficult question for another time.
Should we, Vivian, are you happy to say yes, agreed to take it offline?
Absolutely.
And I know Ed's going to make a suggestion about coming back on this subject. So, Andrew, did I cut you off? Are you done? Ed?
Yeah, thanks. I mean, I invited you along today because I think so highly of you and your work. I guess what we're missing as a system, and it's understandable because this is early days, we don't have an integrated virtual care strategy. And I was thinking about Cassius, in Suffolk, equivalent in Essex. We're not looking at it in the round as yet because it's early days. So I think that if we're going to bring something back, Chair, I'd like to see an outline proposal about how we're going to integrate all of this work into a more meaningful, because that's big opportunity as I see.
Yeah, and I saw lots of nods around the table there. So let's excuse me. Let's say bring back a further update around the integrated care and integrated care system, and leave it to the exec team to see if we can get that into March or May. Yeah, happy with that? Yeah. Okay, I'm going this way now. So Shane.
Thank you. Thanks, Caroline and Vivian, for an excellent presentation. I'd echo Andrew's comments about your strong leadership, both of you actually, in what is a very collaborative programme between our trusts. And I think it's one of the strongest areas of collaboration. It's really encouraging. I think it's particularly encouraging that we're now starting to mature the model together, looking at economies of scale around out-of-hours care and the digital platform. I think that's critical, and I know it was put together in a very short space of time at both ends of our collaboration. So I think that's happening relatively early on in the life of virtual wards, which is good. I note the question from the public, which was in relation to economies and cost effectiveness of virtual wards. I think we just need to remember that this programme is only 18 months old, and you evaluating the cost effectiveness of the service at that point is probably not going to give us the right answer. But the evaluation you talked about earlier, my question was, are we doing that collaboratively across the two trusts to make sure that we're learning as much as we can from the nuances on both ends?
Good question. Go on, Vivian.
Yeah, absolutely. So I chair the ICS Clinical Reference Group, which meets monthly, and of course representation from across the system. And yes, we have discussed that. That is a recent agenda item, and we were looking to see actually which areas we can do together and which areas are particular to our local trusts that we should do within our own teams. So that continues to be on our regular agenda item, and we will try and put that together with Glenn Took and Victoria Ambassador, our system colleagues, that we will be looking at that over the coming months.
Great, thank you very much. In which case, Susanna.
So Andrew and Ed have already stolen some of my thunder, but congratulations, it's an excellent piece of work. I was going to underline the importance of that equality and health inequality impact assessment. The other thoughts that I had were, firstly about, others have commented about this is a really good example of collaborative leadership. And I think that's really important in terms of kind of sharing your learning in that space, because, increasingly that's the space that many of your colleagues will be wanting to kind of get into. And then the other point was that you talked a lot about working with, I was really pleased to hear about the working with care homes. And picking up on the point about, the join up with other systems, but just that conversation with care providers. We've recognised recently we really need to strengthen those relationships with social care providers. So I wonder whether or not, bringing your case study for discussion with social care providers through perhaps Essex Care Association, Suffolk Care Association, and starting kind of to explore the potential for more join up in terms of the work that frontline care homes can work with virtual wards and what further opportunities there might be. Thank you.
Thank you. May I just comment? We are working closely with the ICB care homes team around that pilot, and we're joined up with Hannah and the team at Esneft around that. I think we're very passionate about the care homes pilot. We know that a number of care homes are really happy to accept on-boarded patients back into their in their homes, but some are not so happy. But there's another step for us, isn't there, which is asking care homes to actually identify residents who would benefit from virtual ward care, and rather than ringing 999, and we know a lot of residents actually actively don't want that and don't want to go to hospital and decline that sometimes, but actually would be very happy to come onto virtual ward. So it feels as if that's a very exciting next step for us. And also just like to make the point as well as working with the ICB care homes team and collaboratively with ESNEFT, there is obviously an ICB benefits lead as well. So the evaluation work that we're doing around financial benefits and non-financial benefits is I think, fair to say, very joined up across the system. Would you agree? Yeah.
Okay. So thank you for that, Peter, Vivian, Caroline. Peter, unless you actually want to go on.
One final thing, I think if our GP colleagues were here today, we might have had the question about GP workload. I think it hasn't come out in the presentation, but I think as a team, you've been really successful in not overflowing into general practice, because I think it's part of this less shift strategy which we've got, which is a really great example of. I think that's another part to be commended, and also to keep an eye on as we go forward about clarifying that clinical supervision that's been critical to success. But thanks to the team and everyone.
Yeah, no, thank you all. I think it's fair to say in conclusion that the board received your presentation with enthusiasm and with delight. We recognise it's early days and it's work in progress. It needs more evaluation, but there are also a lot of opportunities to develop further on a system basis. So we look forward to a further update in March or May, depending when the exec team can bring something which is adding value to the board meeting as well. So with that summary, are we content to move on? And Vivian, I know you've got to dash off because you're going back to a ward round, are you not?
Yes, I am.
Yeah, okay. So all done? Agreed. Thank you very, very much.
Thank you very
everybody.
much.
Thank you for having us.
Thank you. Okay, colleagues, we were 10 minutes ahead. We're now 10 minutes behind. So your coffee break is in danger. Let's go on to the dementia strategy, item 13. Richard.
Thank you, Chair, and I'll try and be as succinct as I can. So I'm really pleased to be bringing today our draft Suffolk dementia strategy, and this will be a bit of a double act with Georgia, as we've both been helping sponsor this work over the last year or so. I want to start by just commending Suffolk Health Watch. I know Andy's in the audience, to the brilliant work that Health Watch led in terms of their work on the dementia report, which was really setting out the experiences, the lived experiences of those with dementia, and particularly their families, their carers, and others. And that's really helped in terms of the development of the strategy, plus all the brilliant work that I have to say Gail Cardy, who's a joint post between the ICB and the County Council, has been doing to develop the strategy and include a lot of people with lived experience in its development. So you'll see in Appendix 1 the overall strategy, and it's a key commitment that rose out of the Dementia Action Partnership that we have in place, which brings together service users, their families and statutory services together to oversee our work across Suffolk in relation to dementia. So the strategy itself, as I've alluded to, has been developed over the last 6 to 12 months through a period of co-production engagement across the different sectors and the different partners, and you'll see the conclusion of that in the report. So the report itself, the strategy, you'll see the vision there is that we want to create a society where stigma for people with dementia is reduced and they feel safe and empowered in the knowledge that responsive services are there for them. What we've done is we've set out a series of priorities and then a set of key outcomes for each of those priorities. And then there'll be further work to actually to measure how we're achieving those priorities and outcomes over the lifetime of the strategy. I won't go through the detail of that because you've got it in the pack, but just to say in terms of the next steps related to that, subject to the sign-off of the various forums, including the Health and Wellbeing Board, its next meeting, which is overseeing the overall strategy, we'll be developing co-producing, I should say, a meaningful action plan and set of key performance indicators, both qualitative and quantitative, so that we can be sure that we're developing and implementing the strategy. And we should be getting that into place later this year. So I'll just hand over quickly to Georgia in terms of any further comments.
Thank you very much, Richard. Just a few words to add. Don't want to keep people from their tea break. So we've had the a dementia action partnership we've had in place for probably about 2.5 years, and this was the start of this work that we're doing in terms of dementia. And just to describe the journey a little bit in terms of when we started, the way I would describe the dementia action partnership is there was an aspiration to ensure that Suffolk County Council became a dementia-friendly county. And we had a huge amount of enthusiasm and commitment, which we still do even today. But I think what we lacked was that sense of priority, that sense of what does good look like. And what we now have with the development of the strategy is we then will have a common understanding of dementia, the dementia landscape in Suffolk, and what we want to achieve. And once the strategy has been finalized, as Richard described, there is going to be some work over a couple of months to co-produce an action plan. And we're very keen for that to be a whole systems approach, and actually to be very much led not by the statutory sector, but actually by people with lived experience and community groups. So this is the start of a lot of work, something really exciting, and hopefully you will support the strategy. Thank you.
Thanks, Georgia. Quick question on the scheduling, the sign-off scheduling, Richard. So we're here today, obviously, and it's going to go to the Health and Wellbeing Board in March, I beg your pardon. Do we have a date for Norfolk and Waveney receiving it yet?
I don't personally, but I can find that out. I would imagine it should be to the same timescales as what we're working to, but I'll double check with Gail, who's been coordinating this.
Okay, great. Okay. Questions? Fanuel?
Thank you, Richard. I noticed that in terms of the scheduling, that our alliances are going to be signing this off, but I just wanted to check, and maybe sort of Peter might step in. One of the things that primary care has been grappling with quite a lot is around dementia diagnosis, and I wonder what the how much they've been involved in this process and the consultation around what needs to be done in primary care. Thank you.
Thanks, well. So you'll see one of our priorities is that diagnosis, and it's fair to say that we are struggling still to meet the national standard of 66.7. It's very precise, around 67%. Is the national standard. Now, clearly, we want to achieve 100%. At the moment, both in West Suffolk and Ipswich and East, and I haven't got the exact figures to hand, we're not at that point yet. We've got a recovery plan in place with an ambition to achieve that by October. We are achieving it in North East Essex. I'm really pleased to say that. It's a long time since we did. We are now achieving it, and there's work happening to look across the three alliances through one team that works on this together, led by Chris in my team, around some of the learning from each of those areas. Peter might want to comment about any specific involvement. I know that it's gone to the alliance boards already and it's had involvement from the stakeholders there, but Peter, is there anything you wanted to add?
No, thank you. I think the main thing is because there's a lack of capacity in the NSFT diagnosis service, it's difficult to get GP enthusiasm to put enough referrals through, because it's kind of what's the point because of the waiting time. So I think once we've increased the monthly diagnosis capacity and thought about different ways of doing diagnosis as well across the whole range of presentations, then I think we're in a position to say now we can push this with our GP community, say, look, this has changed now, so that we believe in the system again. Because at the moment, I think it had to work around it because we've had this block. And I guess part of I think we've set a good strategy here, which is lots of principles, but we need to have the JFP alongside this to say, so what are our numerical measures and aspirations alongside this about what it is that will measure our success? And your diagnosis being one of those, we're certainly as an alliance, we've set a particular target with NSFT colleagues where we've seen phase 1 made some good progress, but I think we just need to keep that trajectory clear in our mind of what it is we're trying to do, because we're in a catch-up mode.
Do you want to comment on that, Richard?
Only very quickly. So we have an overall measure. I think, as colleagues know, in the JFP is one of our key measures around dementia. I think, as Georgia and I said, the next stage with this is turning this then into the action plan and then the measurable KPIs alongside that headline measure. But I think if we'd gone way off beam with this strategy and you didn't think it was what we needed, clearly we wouldn't then move straight into the action planning. Just to give credit to NSFT around this, we have put additional investment into the diagnostic service. There's a recovery plan in place and they're already in the process of recruiting. It won't get us completely over the line, but it's a really good start in terms of the additional capacity to deal with some of the challenges that Peter's alluding to.
Okay, thanks. Let's take, and the board always wants to be evidence-based. Let's take that emphasis, and measurables are so important. So, the future action plan. So, Pete.
Yeah, thank you, Richard. Thank you, George. I think it's a really, really good strategy, actually. And what comes across is the relationship, I think, George, that you set out with the ambition to have dementia-friendly communities, with the level of social action and engagement with people themselves and their family carers. So I think the spirit and the sense of weighting that's been given to that comes across in the scale, the range and the depth of the comment and the sentiment that's expressed through this strategy that have come directly from unfettered words of people that are using services. So I think it really has that strong flavour, and that's to be commended in my view. It was a point of consideration I wanted to raise, which was in the context of the point that Kirsten, one of my colleagues on the board, raised earlier on around the extent to which we're thinking about the needs of carers in a moving health and care environment. So, if we're expecting, for example, carers who we know sometimes when their loved ones go into hospital, it does provide them with respite and with a break from that, which may prevent carer breakdown. And we can see, for example, with individuals that have dementia, where there is that persistent and ongoing sense of responsibility for ensuring that individual is safe all of the time, 24/7. How virtual wards, perhaps how we need to make sure that there is a structured focus on the needs of carers at those points when individuals are being supported with complex acute health problems coexisting with some kind of cognitive impairment such as dementia. So it was a point really just to draw out that needs to be considered as we innovate and move forward as well.
And also that make sure that our agendas are joined up appropriately. Yeah, okay. Thank you.
Did you want to just quickly say, absolutely, I agree with you, Pete, and it's down in section 4. So we've got a specific commitment to support to stay well as a carer, and then we've got a specific outcome related to that. And obviously within the action plan, as George has described, we'll start to set out the specifics, and we'll obviously work closely with Kirsten and other organisations in terms of how we can do that.
Okay, thank you very much. Susanna?
So my points are building on others that people have made about the importance of engaging broader partners in the ICS around the strategy, and also making sure that we've got alignment between all parts of our kind of strategy and planning process. So I would kind of suggest that maybe the ICPs, both in Suffolk and North East Essex and also for Waveney, Norfolk and Waveney as well, would be important in terms of the process of endorsing the strategy and making sure that we, check back that alignment with the integrated care strategy and this, because it's really important. And I think the points people have made about the importance to GPs, family carers, and I expect broader, for example, voluntary community sector providers would be really keen to kind of, have sight of this and to be able to input to it.
So a lot of nods to that, Susanna. Assuming that's agreed, can you take that forward through the ICP planning and future agendas? Yeah, everybody happy? Thank you, Andrew.
Just very briefly, there's been a few comments today about respite and how important it is for carers, and I completely agree with that. And it's maybe something for us to take away outside this room about how we provide respite, because it's not hospital admission in the majority of cases, and it's the wrong place to do it. So we need to work out how to do that to support carers. The patient voice in this came out really strongly. I just want to thank you for that. It was a very different strategy to read, and particularly thank you for Appendix 1, which goes not just into protected characteristics, which you don't often see explicitly described in clinical strategies, but also some health inequality stuff at the end of it as well. And I thought that was really nicely set out rather than just a tick box. Thank you.
Okay, thank you.
I can't claim any credit for that, but I'll just say again, Gail Cardy's done an amazing job on getting us to this point with this work. So just put that on record. Thanks, Andrew.
Thanks for saying that, Richard. Let's note that. So always a team game, isn't it? Would it be fair to say that the board welcomed this strategy, notes the great work that has been done from a co-production point of view, notes the future action plan and work on deliverables and measurables and so on, integration with other plans and works such as virtual wards, notes the approval to come from, hopefully, from health and wellbeing boards and Norfolk and Waveney ICP. And with those discussion points as raised, are we happy to approve the strategy? Everybody content? Resolved to approve? Agreed? Done. Thank you very much. So still 10 minutes behind, colleagues, and let me just check with Joe. Joe, did you say coffee is arriving at 11 or quarter to? 11, okay. In which case, let's move on to the Unscheduled Care Coordination Hub. And Paul, I'm coming to you.
Yes, thank you, Chair. I'd like to start by saying a big thank you to Alison Stace and Nicola Cottington, who are joined us out on this for the system. Sadly, they can't be here today. If you remember, one of the previous board, Anna came along and presented, an update as to where we were. We got quite excited the opportunity this scheme would bring, and essentially this is an update where we've got to. So Anna presented some of the challenges, she would say, and there's been clearly a tremendous amount of work that's been undertaken to date, and Anna's going to present that in a second. The other point I would make, and I think, Andrew, you made a comment about the previous presentation around virtual wards being one of those schemes that actually has had an impact on urgent care management. This is yet another one of these schemes that has had an impact this year, I think in terms of where we are today, although we still remain in a very challenged position. I would also say that this is one of these schemes that the more you look at it, the more you think of opportunities. So this will carry on growing in terms of what it can do in two collaboration terms. And then in the background, of course, we are working on developing a business case which actually will look to make this a sustainable model going forward. So having said all of that, Anna, are you happy just to take it through a few slides? Thank you very much.
Okay.
They're in the pack.
They're in the pack. Okay.
Yeah.
I'll just go through the pack. Thank you everyone for having me again. So I'm going to take that we understand what the Unscheduled Care Coordination Hub is. I think I've spoken to quite a lot of people. So I'm just going to go straight to slide 5 and just give you a slight update of what's happened since the last board. We now have a permanent home, and we actually moved rooms already because we got too big. We're in Aspen House in Colchester, and I'm really pleased to say from the 2nd of January this year, we did go to 12 hours a day, 7 days a week. So we're now maximising the potential that aligns with the hours of our UCRS teams as well. So we're investigating and interrogating the stack for a significant period of time, trying to find alternative routes for patients that are on the 9-9 stack to go. We have had non-recurrent funding until the end of March this year, and that's come through a number of sources. The ICB, E-East and NHS have given us some funding towards that. We're undertaking clinical audits, governance audits. We're also doing lots of the quality impact assessments and sustainability assessments going forward. And we continue to scope new pathways to see what's the best possible outcome. This project has always been about improving people's outcomes, not taking ED attendance down or dispatches. It's not about those outcomes, it's trying to get better outcomes for patients. We have got our first 6 months test and learn. So this year has all been about testing and learning. We've given the teams full permission, as long as patients are kept safe, to make mistakes, to try things out, and we've really adopted that test and learn approach throughout this year. We were open 141 days during this 6 months period, with 26.2 patients referred to alternative services and 20.5 ambulances avoided on average per day. There is a difference between those numbers, and that is because we do ask our alternative provider to have a go and triage the case, get lots more information, and then on a number of occasions they go back onto the ambulance stack. 44% of patients this month just gone were upgraded to a C2. So these are C3s to C5s. The information comes through to the 999 service. Our teams do a full triage with them, and then they determine sometimes they are appropriate for an ambulance, or they sometimes get upgraded to a more serious call. One of our biggest successes is that we're able to transfer from 999 to our clinical assessment service run by PPG and give that virtual GP service to these callers instead of receiving a face-to-face assessment or going into hospital. Just going to point your attention to slide 7, which is a retrospective audit. It's been really difficult to quantify the impact of the hub, and are we making a difference? So I was asked by one of our primary care colleagues to do a retrospective audit. So we looked at 200 patients that did follow an alternative pathway and weren't conveyed to hospital, and then we looked at 200 patients that we identified through the hub as could have been suitable, but we didn't have capacity in the referrals teams, and looked at those as our control group. That's the normal that happens when the hub isn't open. And we compared those for a 2-week period, not on the actual a day that they had interactions with the hub, but for 2 weeks after, what actually happened to those patients and their interactions with other services. And the navy part of the chart is those that had interactions with the hub, were referred to a different service, and the yellow are those that followed the control pathway. And we can see that we have a significant impact in the number of emergency admissions and ED attendance. We do see more GP appointments from this audit, and that was to be expected because we are keeping those people mainly in the community to have that wraparound care in the community, and obviously our primary care colleagues are part of that. That might not necessarily be a GP appointment. It could be a paramedic, an AMP, a pharmacy, an assessment going forward. So we have some really strong data there. We have a forecast projection for the number of referrals that we are expecting, obviously opening the hours to much longer. We are expecting more referrals going forward. And this just identifies that we have a gap at the moment between the current service. The dotted line is what the UCRS services are able to achieve at the moment, and they are absolutely fantastic. All 3 UCRS services are kicking it out of the park, to use a young term, to what they're able to take. But there will be a capacity level, and we are feeling that at the moment that they are declining more referrals because of their capacity levels. So our phase, we're very much into our business case at the moment. There are, that's very much looking to how we make this more of a sustainable model for this year going forwards. But we're still going to try and do more, increase our pathways. Virtual ward, I'm really interested in the work Vivian was saying about how do we step up into virtual ward or other alternatives to ED, so SDEX, how do we get those better, and community specialists, long lies, and head injury pathways for falls, because falls does continue to be our #1 reason why people end up on the stack through the hub. We really would like to embed mental health and social care into the hub. There's a huge opportunity for us there. And we need to establish this from a test and learn into a more governed and with clinical leadership on how to take it forward. We are also asked by our NHS and East colleagues to move from, we have a conveyance avoidance helpline model at the moment. What they'd like us to move to is a call before you convey model, which is something quite different. I will take any questions, but there are a couple of case studies that are quite interesting, and I've tried to stay away from the normal falls and just find a couple of alternatives.
Okay, let me start with Ed, and then I'll go to Richard.
Yeah, thanks, Adam. I think the data speaks for itself, doesn't it? The potential for integrated care lift shift is enormous with this, and you know, the potential to integrate 111, 999, unscheduled care, all of it, I can see it. So the business case, I'm looking forward to seeing that. I think it's, as you say, it's exposed the fact around falls. We don't have a level 1 fall service in Suffolk. We have a very effective one in North East Essex. I'm really hoping we see that equity across the patch in the future. However, I've also picked up some comments. There's a comment from one of the providers recently saying, oh, we see limited benefit from the UCCH locally, which kind of, really? When we look at the data. So I just want to understand, as well as the kind of the good news, what are the concerns, challenges, what are the potential blockers to landing this as a system?
Thank you. So it actually does come down to quite small numbers at times. So we look at about 80% of our activity ends up with ESNEFT, and only about 20% with West Suffolk. So it could just be for like West Suffolk Hospital, 1 or 2 ambulances a day that are being avoided because of the numbers. We've only been 8 till 4, Monday to Friday, so we've got this new period where we're going to grow and maximise the potential. We have other pathways that someone that's had a long lie or a head injury that's on blood thinners, we don't refer those, but we could, and other systems are doing it. So I think there's just scope for doing a lot more. So Paul probably wants to say something on scale.
Yeah, if I may, Chair. So just a few things, just to pull a few figures at the top of my head, and Anna, correct me if I'm wrong, but if you look at the projected, sort of, 88 sort of system process we've currently in place, that has the potential, if we trust the numbers, to avoid something like 1,000 ambulance conveyances a year. If you then get into the left shift conversation, i.e. you sort out the capacity issue in the community, you can almost double that. Is the first point to make. Again, if you look at the data, I think it's fair to say when you look at SNF versus West Suffolk, SNF benefit greater than West Suffolk in terms of numbers, and you have a slightly different conversation depending on which operational manager you speak to. But something we do forget is a proportion of those conveyed patients do get admitted and actually have quite 7 to 21 day lengths of stay. And when you start looking cumulatively into those numbers, that's when you start to see the impact. So I think there are ways we can start to measure the impact of the scheme as we move forward. And the last point, I think something we don't often talk about is that this process does shine a light on capacity gap within the systems, which helps us to focus on area where we may wish to commission. And I know you sort of glossed over the falls bit around Suffolk, but we know we could make a far greater impact if we would start to develop the Suffolk Falls programme a bit further. So I think some really great amount of potentials moving forward.
So just coming back to the point, so what's going on in West Suffolk? Because it's second most elderly population in the country. You can't tell me there aren't West Suffolk patients on the stack that can be supported in the community. Is there something we need to do to get a better benefit for?
The numbers actually reflect what's on the 999 stack. What we're able to achieve is quite proportionate, and I've gone through it with Jared in quite some details, and he thinks it's very proportionate to what we normally see. So there isn't a bias. But actually, EIT have longer hours than UCRS and React, and actually take their percentages a lot higher. So they're actually, of our three, our best performing service, so they are taking more than what we offer. It will be around those long lives and those other pathways that we can build where I think we can maximise those numbers.
Okay, so the outcome might be similar, but it's being achieved through different...
But I think they'll feel more.
Okay, happy with that. Richard?
Really, another really good initiative and got lots of potential. A couple of thoughts and then an ask. So I think how it's one of the things for the future is how this links to the localities and our integrated neighbourhood teams. So I know if Maddie was here with some of the work that Claire's doing in her team, is actually how we get down even earlier into those integrated teams, understand the population and get involved with them sooner rather than going through this. So this, if that was all working brilliantly, arguably you might not even need this in the longer term. But I think for here and now, we definitely need to go with this. We need to keep moving. I do think, like Paul, it could bring out sharply some of the gaps in capacity when you increase the hours, because I don't think we're quite equipped with having the response that we could have, like Falls, etc. I'm on a bit of a roll with mental health today, aren't I? I think, again, with this one, this has got so much potentially around mental health. And I know we've started those discussions, Hannah, with my team, but I'd love to link that with some of the work, again, we're doing, Caroline, and if EPUT were here, around the inpatient work, the out of areas, etc. Because I think, actually, even though there's capacity challenges, you may have maxed out with some of these, it could be that this points us in a direction of investment in mental health in some other areas, and we know we've got investment monies through the mental health investment standard. So
just some learning we've had from that. So just before Christmas, there were 18 mental health patients on one day waiting on the stack that we wouldn't usually take into the hub MDT. We were able to do a few, just some one of the case studies in there. So there is potential for doing that, but if we had a mental health practitioner navigating on behalf of that patient, I think that would be the absolute ideal, and it is in the business case.
Let me bring in Caroline first. Now, I know the board's really pleased to hear the joining up that keeps coming through as a theme this morning about mental health, and let's hope we're heading ever closer to parity of esteem in this respect. But Caroline, then I'll go to Paul, then I need to get us moving with Ewan and Janet and Howard. So, Caroline.
Thank you, and I would absolutely concur that it's really refreshing to have mental health continually being talked about. It's brilliant, so thank you for that. I guess I'm still learning in terms of pathways here. What I'm used to from other areas is in control rooms, 999 control rooms, having a mental health presence. So that being police and ambulance, doesn't really matter where it sits, but it's integrated. And obviously, I'm trying to understand what's happening with police at the moment. So I just think there's a real opportunity for us to integrate that whole piece, definitely.
And thank you for that, Caroline. Paul?
Yeah, and that's exactly where I was going actually with this. The thing that doesn't come through in this slide presentation is there's an absolute synergy between this and the system of common sense that we have at the moment in managing capacity and demand across the system, and our ability to react quickly to certain situations and pressure points within the system. And clearly there's a closer working in that sense happening. And then the other point I guess I was going to make is we are being challenged over the coming 18 months, 2 years, to starting to really think about single point of contact as a system. And I suspect this will look very different in 2 years' time than it does now. So it will morph into something else. So we are into that journey. So it's one to watch. I think quite exciting. Thank you.
Great, thanks. Ewan?
Hannah, thanks for including the data around the audit. Can you help me understand it? The graph shows rates per 100 individuals of emergency admissions of nearly 200 in the conveyed group, which suggests there's something very unusual about that particular group of patients to have 2 admissions in 2 weeks. And even the non-conveyed is almost up to an admission each. Is it 100 individuals? Can you help us understand that?
I need to refer back to Jared for that. Can I take that away and get some clarity around that? This is Jared's slides, and I'll get some information for you.
Yeah, just clearly the evaluation of these sorts of changes in care is really important, and when the data looks at it, it suggests there's something unusual about the patients involved.
Yeah, this is very new. This only came out last week, and I included it in the pack because I thought it was important, but I really need to get down to the crux of it. Thank you.
So let's take that as an action and an update to, particularly between the two of you, but to come back to board. But quick comment, Paul?
Yeah, just a very quick comment. Absolutely, I think when this journey started, it was very much about how do we stop conveyancing from happening. But actually, there are some much wider benefits to this. I'll cast your mind back to, and it happens to us, but patient at C3 to C5 waiting 16 hours, 20 hours to have any access to care of some description. This so convinces that, and actually, from a quality point of view, absolutely is really quite helpful. So, and also it's also supported our ambulance services colleagues in terms of C2 response as well. So again, there are other wider benefits that we should consider as well as access to hospitals.
Okay, thank you. Janet and then Howard.
Thanks very much, Chair. And Hannah, thanks for the presentation. It really does show the impact of the hubs. And I'm struck by the impact of the hubs, but also the impact of the virtual hospital that we've heard about earlier. And it strikes me strategically there are some decisions that we need to be made rather than looking at all of these in isolation and sort of strategically as a system, but then also taking in the alliances and it being nuanced to the population. So I just wonder how we can take some of that forward so we're not looking at everything in isolation, and obviously bringing in the mental health side and the mental health investment standard would impact into that as well.
I think, should we say, yeah, noted, agreed? Yes. Howard?
I suppose it's a similar theme. I mean, Hannah and I have been talking quite a lot about this one, but in my earlier presentation on next year's planning, I alluded to the fact that there are a number of cases and that still need to be brought forward that we're going to have to make some decisions on. This is one of those, and I think there's something for me. I agree with Janet's comment. There's something for me around initiatives like this, like the virtual ward, that aren't just about the here and now. They're also about how we sort of live within our means over a much longer period of time. And we need to think about that in that sort of context as well. Yeah, just wanted to say that. And unfortunately, we're sort of running out of time a little bit, aren't we, Hannah? So I think it's just there's an immediate pressure in terms of trying to come up with a resolution for ongoing funding. But there's also a test for us as a system about how we invest in initiatives like this, like Virtual Hub, for longer term sustainability. And we can't have it as a ICB thing or a trust thing. It's a kind of we thing. That's really how we have to be able to do it. Thanks.
Okay. So, colleagues, would it be fair to say that we gratefully received and with enthusiasm received the reports? Thank you very much, Hannah and Paul. We note that it's part of the future planning and yet to be resolved, but I think it's fair to say that the board is supportive of the continuing developments in this direction, and noting the point that was made that by a colleague who, I can't remember who made it now, that this is early days, but it's all part of our integrated system working. Happy to support, note and endorse? Done. Great. Okay. So everybody, it is now 4 minutes past 11. I think we need a quick break, and then we're going to have to be very fast when we come back to finish on schedule. So let's go for a 10-minute break now till 11:15. We'll recommence sharp, but then we've got to motor. Okay? 10-minute break, recommence 11:15. Thanks very much, everybody. Okay, everybody, thank you for that very rapid break. And we are going to recommence. Thank you. Andrew, I'm going to come to you because we have apologies from Lisa. So for items 15 and 16, you've very kindly offered to step in. Over to you.
I'll deal with item 15 first. So this paper describes the progress against the leader priorities. The leader is the review of all deaths for patients with learning disability that occurs on a national basis, and with which we are heavily involved in Suffolk and North East Essex. So it describes the delivery of the priorities within 22-23 and the evidence against that, gives a summary of the leader reviews that have been done and some themes that come out of that, and then describes the priorities for 23-24, which we have been working through. And just for awareness, they comprise LD health checks, learning disability registers, completion of DNA CPR forms, screening and immunisations, training, reasonable adjustments, and continuity of care. Happy to take any questions.
So, board members to note, obviously it's a 22-23 report, so somewhat aged now, and an update on the 23-24 priorities, and of course we're not that far off the end of 23-24 at the moment. We're only asked to note, Caroline?
Yeah, just how impressive it is, the physical health assessments, really, really great. Must be near the top in the country, so well done to primary care and partners around that. That's really good to note.
It's been a huge effort to get there. A few years ago it would have looked very different, so yeah.
Brilliant, well done. Thank you.
Thank you for that, Caroline. With that comment, are we as a board happy to receive a note? Done, thank you. Sticking with you, Andrew, for 16.
So item 16 describes our safeguarding activities. It describes the extent of partnership working with both Suffolk and Essex County Councils, the achievements from 22-23 and also the priorities for 23-24, again, which we have been working through, and then some important feedback from the team of how they feel working in safeguarding, which I think is useful, and a different perspective on the work. Again, happy to take any questions.
So again, noting that it's a 22-23 report with 23-24 actions. Any questions, points? Happy to receive a note. Done. Thank you very much. Item 17, Susanna, ICP update.
Okay, so I'm under some pressure here to be brief, so I will be. So my report gives an overview of the items that were discussed at the last meeting of the Integrated Care Partnership and some of the key things that were agreed by members of the ICP. I've picked out three items in particular for sort of special mention of this. The first and potentially the most important is that in November we embarked on a new system learning programme around exploring systemic injustice really in health and care in Suffolk and North East Essex. So this programme entitled Uncomfortable Truths, we're deliberately working through in 3 stages. At the first stage, really leaning into the why and the experiences of people locally. I don't promise that anything's going to get any less or any more comfortable, any less uncomfortable at stage 2, where we're going to be exploring how, including how perhaps many of the attempts that we've made to address these issues have not been successful in the past. And that will be on the 1st of March. So that's a really important focus for us, and I think a piece of work that hopefully I'll be coming back to the board to show you how it evolves over the year. The other one, which I'd just like to mention briefly, is credit to the ICB alongside Essex County Council and Suffolk County Council, who have now put in place implementation plans for a new way of working around underpinning sustainable investment and funding in voluntary community and social enterprise sector. So that's a new piece of work. There's a good practice guide, which we've now has been endorsed by the ICP and was also discussed at Essex Health and Wellbeing Board last week, with support from the 2 integrated care boards across the other 2 ICBs across Essex as well. So being brief, I shall end there.
Thank you very much. Any questions for Susanna? Otherwise, again, we're asked to receive a note, duly received and noted. Thank you, and we look forward to the future events, of course. Thank you. Moving on to item 18, the amendments to the ICB's constitution, etc. Amanda?
Thank you very much, Chair. So a lot of what's in this report we have previously spoken about at the last board meeting in particular. And really what this report does is tie that conversation with now what we're required to do with regards to the 1st of January in accordance with the provider selection regime. So it's knitting those two pieces together. And basically this report is recommending to the board that we actually look to increase our non-executive members from 4 to 5. And it may well be that we keep that 5th NEM vacancy or we actually recruit to it, but it gives us the opportunity to increase in line with other systems. It also enables us to remove the live or work criteria from our constitution, which is really subject to local determination, and from looking at other constitutions, many systems have now removed. So this report is recommending that we adapt and update our constitution to remove the requirement that future NEMs have to live or work within our SNE area. And then the final recommendation associated to our constitution is to really support our succession planning around something that we have previously discussed before, and that is to start looking at local recruitment to NEMs in the context of associate NEMs. And I would propose, if we support that, that piece of work is taken through our REMCOM accordingly. Thank you, Chair.
Amanda, thank you. And noting that this paper was requested at the November board and hopefully delivers on the expectations that you had as a board at that time. Any questions for Amanda? Otherwise, we're asked to approve as presented. So resolved. Thank you very much. Thank you, Amanda. Thank you all. Amanda, I'm going to stick with you for item 19, which is the governance self-assessment.
Thank you very much. So we've previously mentioned this at the beginning of the board meeting. It very much is a work in progress, but members will recall earlier on in 2023, NHS England recommended that all boards carried out a self-assessment to aid the partnership and the further development of boards going forward. It is halfway through, and what this report illustrates is where we are by way of interim. So we have, I think, 13 out of a possible 25 that have completed and returned. I would urge members that haven't completed to take, I think, a hard copy that has been circulated and returned to myself or indeed Tom ASAP. And then what we plan to do is collate all of the responses and bring a final report to our board in March. But this report shows where we are in that we have some areas of improvement and we have some areas of strength. Thank you, Chair.
Okay, thank you. And if I, as I said right at the beginning, if I could encourage board members, please, to return your self-assessments. It is part of our, well, never ending really, but maturing of our very new board. So it's really important that we hear people's thoughts, understand your points of view, and then take them into account in future development of the board. So further report then would be possible in March. Okay, any questions, points there from? Nope, all done, thank you. In which case then, moving on to committee minutes and highlight reports. Amanda, there are 10 here. I know it's got your name against it. Should we take these on block, or did you want to go through any in particular or raise any particular points?
I think we could take on block, Chair, and maybe pick up any matters by exception. Mm-hmm. Thank you.
Okay, so let's do that. We've got 10 minutes for reference and for the board to note. Any questions or points from any of those reports? Otherwise, received and noted. Duly done. Received and noted. Thank you very much. The attendance log is again there for you to receive and note. Any questions therefrom or points arising? No, received, noted, thank you very much. Any other business? Actually, I've got one point which I should have mentioned, Tom and Joe, to make sure we capture in the minutes that Paul had to leave the meeting. We did actually record Paul's apologies right at the beginning, but then he was able to show he wasn't totally 100% well, though, was he? So thank you to Paul for coming anyway. But Peter, sorry, I keep saying Paul. Pete, yeah, my fault. But Moira, over the coffee break, Moira's replaced. So as long as we capture that, thank you, and apologies to Peter Paul. Yeah. Any other business? None has been noted to me in advance, so I'm looking around the table as I go. So any other business? None raised. Wonderful. Date of the next meeting, 26th of March. And then questions from the public. So right at the beginning, we elected to deal with the questions from Mr. Dooley in writing. So we'll add written responses in the normal way to the minutes. Are there any other questions that we know of that have come in? I'm looking at the team at the back to flag if nothing has come in. Okay, so nothing during the meeting, in which case, so at just before 11:30, I think we can say meeting complete, meeting closed, done. Thanks, everybody. Thank you very much. And well done for finishing